Hello, and welcome to this AcademyHealth Google Hangout, Innovation in Safety Net Hospitals, What's the Role of Research Evidence? My name is Lauren Gerlach, and I'm on the staff at AcademyHealth. As you may know, AcademyHealth works to improve health and the performance of the healthcare system by supporting the generation and use of timely, relevant research. Part of our work involves speaking with leaders in health policy and healthcare delivery to better understand their priorities, how they work, and what types of information is most useful to them. Over the past couple of years, support from Kaiser Permanente has enabled us to take a closer look at the experiences and evidence needs of safety net healthcare providers, which is the focus of our conversation today. We have a terrific panel of speakers who bring a mix of practice, policy, and research expertise, and who can provide some real insights into the realities of using research to help inform patient care. So with that bit of background, I'm pleased to introduce Cecilia Echeverria, Director of Safety Net Partnerships at Kaiser Permanente, who will moderate today's discussion. Cecilia?
Hello, and welcome to today's Google Hangout. I'd like to just start off by sharing that Kaiser Permanente and AcademyHealth have had a long-standing relationship. And AcademyHealth is a national leader in the field of health services and policy research, and their membership is made up of professionals like all of you who produce and or use this work. Our organizations have common interests in research areas which include population health, healthcare innovation, care delivery, and the focus of today's Google Hangout, safety net populations. So this work on safety net hospital systems is part of the Innovators in Residence program of AcademyHealth Translation and Dissemination Institute, which is aimed at moving the findings of health services research into policy and practice. I'm particularly pleased, however, to say that Kaiser Permanente provided support for this important work by Dr. Linda Cummings, one of AcademyHealth's Innovators in Residence. This work helps us better understand and respond to the needs of safety net healthcare providers and their patients. Kaiser has had a long-standing commitment to safety net providers and patients. We've been proud to support efforts to improve clinical and financial as well as operational strength for the safety net providers, improve access to care, improve patient experience, affect policy change, and improve social and economic conditions that impact health. The purpose of today's event is to highlight innovative programs in safety net provider organizations and the opportunities and challenges that providers face in finding research to help inform their work. These programs were highlighted in a series of briefs developed by Dr. Cummings. So let me share a little bit about the flow of today's Hangout. First, we'll hear from Linda about her work with AcademyHealth to better understand the use of research and other evidence in 3 safety net hospital systems. Then we'll turn to the leader of one of those systems, Anna Roth from Contra Costa Regional Medical Center and Health, to discuss Contra Costa's approach to research and innovation, and in particular, their experience leading up to a recent partnership with Health Leads. We'll be sure to have time for questions from all of you as well. Today's event is meant to be interactive, so we'd like to encourage you to submit questions for the speakers throughout the event. To ask a question, click on the small box in the upper right-hand corner of your screen. You'll have the option of pulling up the Q&A box, where you can type in a question, and you should feel free also to pull up the showcase feature, where we've posted some materials relevant to today's event. So without further ado, let me introduce Linda and the Innovators in Residence program. Linda provides research and program development consultation focused on the health status and health care of underserved populations. She was formerly Vice President for Research at America's Essential Hospitals, where she directed the Essential Hospitals Institute. While at EHI, she developed the organization's research agenda around system redesign, quality, performance, and improvement in patient care, health disparities, and the financial and operational characteristics of safety net hospitals. In 2015, Linda served as one of AcademyHealth's Innovators in Residence, a Kaiser-sponsored fellowship that aims to improve the translation and dissemination of research findings for the benefit of vulnerable and underserved populations. Linda will now share a bit about her work with AcademyHealth and the findings from a project to better understand the use of research in safety net hospital systems.
So thank you, Cecilia, and thank you, Lauren. And I'd like to thank Kaiser Permanente and AcademyHealth for this opportunity to look at the use of research in safety net hospital systems. As Cecilia mentioned, I was Vice President for Research at America's Essential Hospitals, so I worked with senior clinicians and administrators in safety net hospital systems to identify and share innovative approaches to caring for their patients. And as Cecilia mentioned, one of those senior administrators that I worked with very closely was Anna Roth, who's CEO of Contra Costa Regional Medical Center. And I saw at firsthand how deliberate and how entrepreneurial they were in developing initiatives to provide better care around specific conditions in their patients and improve the overall health of their communities. And I also had a chance to see the excellence of the results. And I also saw that they had a great deal of interest in learning from other organizations with the same patient profile. So the Innovators Project at AcademyHealth and AcademyHealth's work on the translation and dissemination of research provided a setting to look directly at the use of research in safety net hospitals in developing these patient care initiatives, how the research was conducted, how it was applied, and the challenges they faced. So I profiled 3 organizations, but I wanted to mention that there are many other similar organizations across the country that are engaged in precisely the same kind of efforts. But the 3 hospital systems provided an opportunity to look at different approaches to improving care for their patients. At Contra Costa Regional Medical Center in Northern California, they built a comprehensive program to address the social needs of their patients. And Anna is going to talk more about that. I'll talk a little bit about it, but she's going to go into it more later on. Grady Health in Atlanta developed a heart failure clinic to reduce persistently high readmission rates for heart failure among their patients. And at Metro Health in Cleveland, in partnership with Case Western Reserve University, they established a center for reducing health disparities to address the prevalence and impact of disparities among their patients and in the greater Cleveland community. So what did I learn about their capacity to generate their own research and where they were able to find relevant research? And I think the first thing that in general that I knew, and I think, but I've heard occasionally people make an assumption that there isn't a capacity for research or an understanding or comfort level with research in safety net hospital organizations. But in fact, these organizations have senior clinicians, administrators, and providers who are experienced with research design and evaluation, and with peer-reviewed literature. And so the challenge isn't around having personnel who recognize the value of research. The challenge actually boils down, in my view, to 2 big issues. One is a lack of resources to support sufficient internal research and evaluation capacity within the organization. And that is true even in those organizations that are affiliated with academic medical centers. Although they may have more resources, I would say across the board, there's just a lack of sufficient resources to have a dedicated research staff. And then more globally, there's a lack of sufficient research on underserved patients and the cause and treatment of health conditions in these patients, the impact of social determinants on their health. So when these personnel go to look for research to help guide the initiatives that they're developing, they can't find sufficient information. So how did they approach this research? Each of the 3 spent time at the beginning to define the problem as it existed in their institution. They turned to the published literature then, they looked to other organizations both in and out of the safety net, and then they developed an approach that was framed by their own organization's culture, its resources, and the needs of their patients and their community. At Grady Health, led by a physician, they organized a task force that included administrators, cardiology faculty, providers, and patients who began with a review of Grady's patient data, looked at clinical studies, and then practices at other hospitals. At Metro Health, where they developed a Center for Reducing Health Disparities, their research framework reflects the clinical specialties of the co-directors, which are nephrology, pulmonary disease, and care in the ICU. But the center's work is directed at the vacuum in the research in these clinical areas around caring for underserved patients. They also define their mission very comprehensively to address the health needs of the greater Cleveland community. So its mission includes education, community, and policy engagement. They created a community research scholars initiative and a collaborative to build the research capacity and knowledge about disparities in the Cleveland community. And at Contra Costa, Anna will address this work more specifically, but I found there, as in other places, that the clinicians and administrators started first with defining the needs of their patients. And in one of Contra Costa's 11 community health centers, one that serves about 100,000 patients a year. So they established a working group that includes nurses, social workers, frontline patient care staff in this clinic. They surveyed the patients, turned to the published literature, and then cast a wide net for other examples of initiatives that address social needs before partnering with health leads. And as with the others, they defined their efforts in the context of their organization, their community, and their patients. So here's some lessons learned that researchers can have as a takeaway. First, research for safety net organizations needs to derive from the needs of the organization, not strictly the interest of the researcher or of the funder. I would say that Kaiser Permanente is exceptional in the fact that it puts its resources directly at the needs of safety net organizations, and it's very much a partnership in defining what those needs are and in the real time. So I think that is something that stands out, because often funding opportunities, which drives where researchers focus, are not really relevant to the current needs of safety net organizations. Helpful focus for researchers is to focus on program design and evaluation. That I think in both having sufficient resources and information to help design a program, there's also a lack of resources to evaluate the results of those programs and to help refine them. Also, ensure that research is driven by the needs and characteristics of the patients and the culture of the institution, not a global sense of what is needed, but really directed and focused on the needs of that particular institution. And then, of course, it's essential that this research contribute to the body of knowledge that aims to reduce health disparities. So with that, I will turn it over to Anna.
Thank you. And, first, I want to thank Academy Health and Linda in particular for featuring the work that we're doing here at Contra Costa. I've had the privilege to work with Linda for many years, and have always found her to be a tenacious leader in working with safety nets and working specifically on equity, something that I think we share a long-standing passion for. I also want to thank Cecilia and Kaiser Permanente Community Benefit. They have been long-standing partners with Contra Costa. We share the care in a community. We coexist in the same landscape with Kaiser, and we have consistently worked in partnership with Kaiser over the years on many things. I think that what I'm going to talk to you about today has been one of the more exciting things. And so I just wanted to start by saying how pleased I am to be here with you and contribute to the conversation today. I want to talk about where we began. I think, to Linda's point, we started by going out and asking the patients, what matters to you? What are your main health concerns? And, there's a lot of literature that guides us and tells us, safety nets particularly have this strong prevalence of chronic disease in their communities. We have a lot of what many people will say have a high burden of mental illness, substance abuse. So we decided we would look in the literature, and we wanted to know what really mattered to our community. And it was pretty aligned with that. Think about chronic disease, think about obesity, think about, even if you really want to get upstream, think about graduation rates, standard health maintenance that we all sort of think about. So we went out into the waiting rooms, though, and we started to ask the patients, tell us what matters to you. And that's not what they said to us. They said to us, access to food, nutritious food. That's what matters. 62% of the patients sitting in the waiting room told us this. They said housing, jobs. We need access to supplemental support for our energy bills. We need help renewing our medical insurance. So we started to rethink how we were approaching health in our community and care for our patients. The other thing I think to recognize is that this is what our providers are facing every day in the exam room. They have their 15 minutes, and in this 15 minutes, they're trying to address diabetes, address a number of chronic diseases, a number of family medicine kind of issues, and really they know that their patients don't have access to food, or maybe that they're going to go live in their car, and this is a tremendous burden for our providers to carry every day, and our system really decided we needed to find a way to take this on. So I'm going to start by sort of our 3 lessons. I'm going to start by saying we decided that we wanted to be bold. So lesson 1, be bold. And we reached out to our friends at Kaiser Community Benefit, and it turned out that they were actually thinking about these same things. So we partnered with them, and we did look to the literature, and there isn't a lot of evidence-based models out there really that are proving at scale how you address social needs in a healthcare setting. So we went through our relationships with Kaiser. We found a proven model in health leads, and so through the support of Kaiser, we partnered with health leads and we brought them into our clinic. Now, I just want to say this again to Linda's point. We did not have a lot of information. There was a dearth of research actually out there to really draw from. There's a lot of hunches. There's a lot of intuition, and I think this makes very good sense. But what we wanted to do is be able to plug in a proven model or bring in a proven model. So we had to work very closely with our providers to adapt this model to our local environment. And we also work, and I think very happily, Kaiser has a clinic very close to ours, so we formed a learning system with the Kaiser Clinic that was within a couple of miles of our West County Health Center. So together we both put in these desks, and we started to share the phenomena, what's going on in these desks. And this is another, I think, important thing about researching within the safety net is, though we're very different, we're not that different. So we found out that Kaiser, then the population Kaiser was serving, was seeing they were having many of the same issues raised within their population in their waiting rooms. So that's sort of, I think, myth bust number 1, is that the safety net, is not necessarily as different as you think. I think the second sort of thing about the second thing I want to say is to be brilliant. So we had to adapt this model, and so we went to our providers and we went to our partners with Kaiser, and together we created a lot of space for our Kaiser colleagues and our Contra colleagues to get together and think. And they came up with sort of a way that we would do real-time evaluation, a way that we would track. They worked with our electronic health record vendor to sort of build in workflows into our health record. And I think that creating the space outside of the box is really important. It's a really important thing for leadership. We also attached our county epidemiologist to this, and I know Kaiser attached their evaluation team to it because we knew both of us could not find evidence, so we felt like it was really important that at the end of the day we are able to contribute to the body of knowledge that we hope is forming around meeting social needs. I think to the other piece of this is another thing why I think it's so important for safety net organizations to be, for research within the safety net, is I think we do represent a huge piece, a huge swath of the population. Often research is conducted in a sort of a set of usual suspects, if you will, and there is a certain type of research generally related to equity that's going on in the safety net. But I do think we represent Main Street USA. I think if you're talking about generalizability scale, then you have to include the safety net. The other thing is that this safety net, we are carrying this huge burden or this huge piece of the newly covered population. 1 in 7 people in the United States are now on Medicare and Medicaid, and so this is a huge group of providers to leave out of the center of research. And finally, around the importance, and I think why it's brilliant to work with a safety net is because it's true what Linda says. We were very deliberate about it because we don't have an excess of resources sort of laying around. So we have to be extremely deliberate about everything we're doing. The other thing is many of us are publicly owned, and we need to really be accountable to the public and to the taxpayers who are supporting our organization. Finally, I just wanted to say that I wanted to talk about the importance of being able to tell the story of what's really happening and where I think research could also help us. We found that in our first year, the average person, we saw 1,700 people at our health leads desk, which is only in one clinic. We found that we could, in fact, meet certain needs. There were certain needs we could meet fairly well, like over 50% of the time we could meet hunger or access to food. We were able to make that connection with a food bank. The areas where we really still, have a lot of work to do, where we are making much lower success rate, is housing. I think, that's, and I think that's what we're seeing now as we move into the next Medicaid waiver here in California. Housing is becoming a big deal. How do you address housing for these population? So I think it's starting to help us understand what can we successfully address, and then where do we still need more work. And so certainly I think as we evaluate our program, I think it will help guide the research portfolio. So I would say my final sort of message is to be brave to the researchers. Don't shy away from the safety net. We have, I think, a lot to share with you. We have a lot to teach. We have this long-standing commitment of working with those, the underserved, and I think the time is now. We have now, many of us have electronic health records in play. A lot of us now have managed populations. So I think that, the access to sort of data and the ability to cull knowledge out of the safety net has never been better. So I think this is a really exciting time. I hope that we continue to focus on understanding the return on investment for supporting the investment and meeting social needs, people's most basic needs. One of the sayings that we have at Contra Costa is that we do common things uncommonly well. And I would like to think at the end of the day that when people come to us, wherever they come to us across the country, that we meet their needs. And knowing how many basic needs are still really going unmet, I think that this should be a challenge to all of us to rethink, regroup, and find ways to address this as part of quality health. So thanks for letting me share that.
Great. So thank you both. And I would like to go ahead and ask folks that have questions to please go ahead and click on the small box in the upper right-hand corner of your screen and pull down the question and answer box where you can type your question. And folks from AcademyHealth and I will be reviewing those questions. But I'd like to start for both Linda and for Anna with a question about what you think is the biggest mistake that researchers make when coming to a safety net organization to start to conduct a research study about safety net populations or providers.
Well, from my experience, I don't know that the mistake is on the part of the researcher. I would say that the mistake often is, I think, where the funding comes from. So I think that researchers, it's not that people are coming in generally, with endowed chairs and the ability to sort of define their own research interests and have support for that. I think that people respond to the funding initiatives that are out there, many of whom have can be very beneficial, but I think for safety net organizations, and I can only speak for them. I think Anna's right. It's often not exceptional in that way. It's not often not unique to the safety net what I'm talking about. But I think that the initiatives that I looked at tended to be in response to a particular need that the institution saw, that the organization saw, that was a pressing need, that needed, they were trying to solve a problem. And I think that the match between the organization's need and what the funding sources have available and the time frame and all of that is often a mismatch. So I'm not so sure that researchers are primarily the ones who are kind of, I mean, at fault is not what I mean, but they're not primarily the ones who are unable to directly address the research needs because of their own interests. I think it's because they're responding to funding. And that's why I, knowing Kaiser Permanente well, would say that this partnership, which really works closely with the organizations to define what their needs are, can drive the research in a way that's more beneficial for the organization.
Thanks, Linda. Anna?
So I totally agree with Linda, and I think I would just add that I think that researchers would be well served to understand that when approaching or considering a safety net organization, that I think this is Anna Roth's theory, is that we do not have the level of competency that some others have that exists in a market-based, in a different kind of market. We don't tell our story well. So I think that when a researcher could, pass us by, sort of missing what's really going on because we don't have the skills to tell our story in the way that others maybe have had the opportunity to sort of really perfect or cultivate. And that is because we haven't had the same kind of market forces and market strategies that I think others have. I think it's changing now. And so I think, this is an opportune time. I think you're seeing safety nets wanting to talk about what their value proposition is. And I think that we would welcome researchers, and I hope they look our way and they come back to us. And, just as I think Linda did this last year, who, she knew what was going on inside of the safety net, so she, came in. And I do think that if you're not affiliated with a large academic, you may not be seen as a usual suspect. I think there's, to researchers, there is a lot of, there's a treasure trove out there of innovative programs that are going on because they had to be innovative. The safety net, they have to figure out how to do it. There is no other option. So I would love to see a partnership with much more the research community coming in and really telling the story of what's actually happening inside of the safety net on the ground.
Thanks. We have a question for you, Anna, about whether or not there's a loopback mechanism in your system when you've identified someone with a need like food, which you've described earlier.
Yeah, can you say a little bit more about the loopback?
So it says, basically, can you address how you capture the success of the referrals, is the question.
Oh yeah. So we actually work with health leads, and it's actually inside of a database. It's a database called Reach, and there are advocates attached to that. There are advocates that are they are volunteers that work the desk, and they make minimally and approximately about 4 contacts with the person who has the need, and they don't just make the referral, they actually then make follow-up phone calls, and then we track that in the database, and we also get feedback then from the patients, like, was this a high quality service, yes or no, and we track that as well. So not only do we track if a referral was given, we track was an actual connection to the need made, and then finally, what quality was that connection? Was that need or that resource, did it actually meet your need? Was it high quality? For instance, if you went to a food bank, did they have the nutritious food available all the time? Is it only available 10 a.m. on Tuesdays? Those kind of things. We start to get the nuance, very much like a Yelp.
Great, thank you. So I think the next question, we'll start with Linda, but I think both of you might have some thoughts on this, is for researchers that are outside of the safety net, that are developing health system innovations, what would your recommendations be about those folks coming to the safety net to help disseminate and implement some of their findings?
Well, I think there's a tremendous opportunity for that, and I think, as Anna mentioned, many of the patient care issues that the safety net is facing are relevant to the health system as a whole. And so I think not thinking of innovations that in the safety net as a unique kind of occurrence. I think that's the first thing. I think it's great if people outside the safety net want to work with safety net organizations as they develop these initiatives, but I think, and I think there are opportunities through organizations or associations. Many of the people who lead these initiatives within the safety net participate in professional organizations, attend conferences, in opportunities that funders sponsor. I think working with the CEO in a community setting is often a way to bring that in. But I think it's important to keep in mind that it's not an opportunity to sort of graft an external innovation onto the work in a safety net. That I think, at least what I found, is that the successful efforts tend to be driven by an organization's particular need and the needs of their community and their patients.
Anna, any thoughts?
I mean, I would agree with that. I would say that the way in is to understand what it is you want to really understand, what it is that you're interested in, and then start to have a series of conversations. I think that researchers will find a wealth of programming and innovative approaches, including, I think, some of the most innovative population management strategies, inside of the safety net. And so I think, that just starting to have conversations and getting out there and networking is the way to go. There are so many inspiring, interesting programs in the safety net. Two others of which that Linda featured, but I mean, we could just spend a whole day talking about some of the amazing things. I almost, hesitate to call out, but I mean, New York Health and Hospitals, Hennepin, Denver Health. I mean, there is so much going on. San Francisco General, that all the Bay Area publics are really doing cutting edge work, and I think that it's actually this is a landscape filled with opportunity for researchers and evaluators to really come in, and I think we want to see researchers and evaluators come in because safety nets have been working at the community level for decades, and so we have been, and we have worked always. I think we have a long tradition of working in partnership with public health. So I think as now the whole country is thinking about managing populations, we're thinking about health beyond just health care, then now I think the safety net really has a primary and a very prominent role to play in research. And what I think is we need to quickly build bridges between the research community and the safety net to really start to shine the light on the amazing work that's going on across the country in the safety net institutions.
Thanks, Anna. Again, I'd like to encourage you all that are with us today to submit questions. This question's for you, Linda, but were there any surprises for you as you interviewed the three systems? You've had a lot of experience with the safety net. Was there anything that surprised you in talking with these three systems?
I thought about this question a lot, and I think the characteristics and the kind of common attributes that I found across the systems were not really surprising to me, because I've spent a lot of time working with these organizations and others across the safety net. I guess what was, and I don't know if I would use the word surprising, it was a little, or it was disconcerting to see that this issue of not being able to find sufficient research about the social determinants of health or about underserved patients in a particular, around a particular condition, that those were so persistent, because it's not a new issue. People have been talking about how important that is in the area of research, and so it was a little not surprising, but maybe a little disappointing that that still tended to be such a barrier and such a challenge as organizations tried to work on a particular issue. I'd like to say something more upbeat, but I think that's also a message for researchers as to how important it is, and sort of a way in to think about the value of research to the safety net.
Thanks, Linda. Anna, for you, what information do you wish you had had when you were trying to consider strategies for addressing the patient's social needs?
You know, I wish that we had a swath of literature, a swath of peer-reviewed data that tells us, you know, how to improve health, particularly what the social determinants, you know, what the role of social determinants are. And frankly, I mean, we talk about it. The other thing I think that I wish is that researchers could help hospitals and delivery systems understand our role in health as it pertains particularly to social determinants. So when we sort of started to talk about this, people said, why are you talking about this? I mean, that's public health, you know, why are you doing this? And I think that we need backing here, and I think research, because we don't have research that says, you know, health systems have a role in linking people to nutritious food. Health systems have a role in linking people to, you know, employment and housing services. That, in fact, health systems' role is to meet the needs of people, and particularly the things that are interfering with optimal health. And so I think that that research just isn't there. I wish I could say it was, but when we went out and we talked to patients and they're telling us, you know, 62% of the people identify access to food as their #1 health problem, and I go to the research and I can't even find it. That says, you know, I think there's some wide open space here for research, and I think to that end, I think it's urgent. That we address this in the research, because policy is changing rapidly. And, you know, happily, policy, we're at a point, I think, a historical time, you know, in healthcare and healthcare policy landscape. You know, we've ushered in the ACA, and we need information. We need to be having the right conversations, and we need to have them right now. And so I think that making sure we're contributing, this will help the safety net truly contribute to the conversation, which I think we've had some voice, but I think we need to amplify our voice in this discussion. People are waiting, people are suffering, and I think that this is unneeded suffering. We can prevent this. And so amplifying the voice of the safety net, amplifying the voice of the people in our waiting rooms, you know, and truly understanding, being very deliberate about what it is we should be aiming for in health reform. This is a very crowded landscape, and everyone's weighing in on this discussion. So I think research, you know, the more research can offer, I think, information to inform the discussion. I mean, you know, as we listen to the discussion going on nationally in health policy, you know, it's a pretty wide variance of beliefs out there, and I think it's important that we have we put to bed, you know, this notion that social determinants and healthcare are not related. I think all of us in health know it, but we need the policymakers to know that now. We need funding streams to match that. We need to make sure that healthcare systems and healthcare coverage match the needs of the patients. And so I think that you know, that's what I'm hoping, you know, is sort of the next step, and I hope that researchers really feel this call to come to the safety net and work with us, because we are really willing partners.
Again, opportunity to pose your questions in the question and answer box for folks with us today. Question about any advice that you have for folks that are early in their careers as researchers around trying to get practical experience in the safety net.
So, you know, someone who's a researcher and has not embedded in a particular organization, my advice would be to a young researcher is to work in a safety net organization, to work directly in some capacity. There are many opportunities, but I think to work in a capacity where you are really understanding the needs of the patients and you have an opportunity to see how the organization addresses those needs and the challenges and the resource issues and the partnerships that the organization forms in order to care for their patients and for their communities. I think that kind of initial career investment is something that will pay off a researcher's entire career, because I think it gives you an understanding and a perspective that is invaluable and that is will ground your interests or the career trajectory of a researcher. And I think that's almost irreplaceable. You can certainly get it without having that, but I think if you truly want to work with the safety net and to benefit the safety net, and as Anna said, to amplify the voice of the safety net and to contribute to the health system as a whole, I think that it's important to start with that, to start with practical experience.
Thanks. Anna?
I would echo what Linda says. I think the path forward really is to get as close as you can to the work, and take the time. You know, I think that we have a lot of students come in, and I know other safety net organizations do, as do all organizations probably. I think take this time to get as close as you can to where the work is occurring. There are so many things that can pull us away, and I would say to researchers, it's so important. I think Linda said this a little bit earlier. Go with an open mind and let the needs of the patient guide you. I know there's a lot of pressure in sort of to kind of follow a certain path. But I think the most exciting opportunities lie where in the path that's less traveled. And so as close as you can get to where the work is occurring, as close as you can get to where the needs are unfolding, which is really as close as you can get to those being served in the safety net. I think that will be a liberating experience, and I think it will also be informative for the rest of your life. I would say to any student, I actually have a college age student, and I say to them, take the time now to sort of go inside in where public service is occurring, and really get as close as you can to it, because it's absolutely breathtaking what's going on, and I think it's not well described, and so I would love to see a couple hundred very talented researchers decide to take this on and to start to describe what's really happening. I also think, again, policymakers are really looking for this kind of information, so go get as close as you can to the work, and that will guide you.
So we have a couple of other questions. So I'm going to take this question, I think, that really relates to our this past little conversation about researchers connecting to the safety net. So we have a comment and a question around researchers getting funded and foundations and government funders being key to support for research studies. So what would your thoughts be around convincing additional sources of funding, whether they be public or private, to invest in research in the safety net?
I think, Cecilia, I was actually going to say, I think it would be interesting to hear why Kaiser has the focus that it does, because I do think that there are a number of funders, maybe not, certainly not enough, but there are funders who do have an interest in supporting the safety net. Whether or not that tends to be a primary interest or one that is really designed in partnership with safety net organizations, I think that's sometimes where where there could be areas of improvement. So I think it would be interesting to hear from the funder's perspective why Kaiser is focused in this way and very beneficial to the safety net in this way. So to turn it back on you.
So happily, our work with community is part of our mission. It's part of who we are. It's not just about our members, but it's also about serving the needs of folks that are in the communities that we serve. That work happens through our community benefit program and beyond. And in our community benefit program, we have several streams of work that really focus on populations that have high needs or maybe at risk. So in our work in the safety net, as I mentioned, we've explicitly called out the need to support our our colleagues in the community who are addressing directly the clinical needs of the patients in community or the members of community. We also, beyond that, we do quite a lot of work around prevention that is also research-based and oriented. So I think Kaiser takes an approach with our community work that mirrors our approach to our own investments in the services that we provide with our members. So this commitment has been sort of a 70-year commitment of Kaiser Permanente, going back all the way to early days of the organization, which was very focused on public health. So those roots of our organization, I think, are really complementary to the roots of the safety net, which are very social justice driven and obviously focused on equity and prevention. So it's just, for us, it's a very natural fit. It's the way we do our work internally, and I think where we see sort of a dearth of information or practice, I think we've been very active in trying to support that. So, Anna, I don't know if you had anything to add around advice for government or private funders.
I mean, I think that, my advice would be that, I would echo everything that you said, Cecilia. And I would also say that a couple of things around getting money, because we're, this is something that I feel like as a quality improvement person at heart, I'm a quality improver. I seek a lot of funding for a lot of projects. In fact, I probably have a call later with you today to look for some funding. I don't, but a couple of things is I think that it's important to remember that perfect is the enemy of the good. So in the spirit of quality improvement, which I think research, there's a tension between sort of research and quality improvement, and is in fact improvement research. And for me, the answer is yes, it is research. So I'll just put that out there. I'll just put that disclaimer out there. And so I think perfect is the enemy of the good. You have to get started. Start where you are. I think that there's the way to actually really seek funding and to secure funding is to be compelling. I mean, have something that actually matters. And if you're not personally compelled, and if you aren't really compelled by this need and this possible intervention to the need, then you won't be compelling funders. I mean, I could just say. So I think that really, go to things, work on things that matter. That's number one. And I think that there's a lot of things that people are working on that maybe are so narrow that it's pretty difficult to get funding. I feel like, and then there are other things that I'm totally perplexed. Like when I think about social needs, which is such a huge issue as it relates to health, I am perplexed as to why there's not more research out there. But I think, after today's call, I know we're going to have a rush of researchers that are ready and able to take this on. But I just think that working on things that matter is really, how you how you find support for your work. And I think that funders want to support things that matter. I mean, I think, making that, starting with that assumption, funders want to work on things that matter. It's your job to now go and find the stories and find the innovative practices and highlight them, bring them, blow the dust off them and get them out there and share the knowledge. We want to know what works, what doesn't work. All of us are heading the same direction. So help us get there faster.
Yeah, I guess I'll build on that as well from my experience beyond Kaiser. Is I do think folks that work in private foundations in particular, which is where my experience is, are open to creative ideas by researchers. I think the researchers really need to do their homework around the goals of the specific organization, the areas of interest, and I do think funders tend to be pretty receptive to pushing their own boundaries. And thinking outside the box to sort of the next issues that might be on the horizon. So I think having open dialogue with a potential funder is certainly something that I would encourage researchers to do. We have another question, and maybe this is a good one for Anna, which is, you said that you've looked sort of out there at the research, and you don't always find the answers that you're looking for related to the safety net populations. But I'm wondering if you've had a good reception when you've thought of approaching, or if you've approached researchers that you thought were appropriate for a specific topic to investigate.
I would say I've always had really good reception when I've approached anybody. I have not approached as many people as I should have. I mean, I think the bridge is not, there, and so we're working on that. We're building that. We certainly have access to researchers, within the Kaiser Community Benefit and their foundation. We are happily located in a very academic region, with the University of California having 2 campuses here in Stanford, and so we have always had very positive reception when we approach a researcher. I think we haven't done enough of it. So I think on to the other direction. We've talked a lot about researchers really need to come and work with us. We really need to learn how to communicate and to reach out with researchers, and I think that this sort of comes back to Linda's point that we are so busy doing the work, and we don't always, particularly the smaller ones that aren't located within an academic medical complex like Contra Costa, we are not. We don't have the infrastructure that others have, and some of those infrastructures, literally by virtue, by design, they have the outreach built in. We don't have that, so we have to be much more deliberate about it, and I think we could do a lot more.
And Cecilia, I would just add that I think that relationship building is critical, and I think what researchers can do is, as Anna said, that safety net organizations can reach out to researchers. I think researchers can also reach out to build relationships with foundations. And if you have a research interest, you can reach out to others in your circle. For example, at Metro Health, when they started with the idea of looking at health disparities, and they did have the good fortune of being affiliated with Case Western Reserve University, but they found that there was a great deal of interest among students and faculty in the issue of health disparities. So they sort of built a community around that. I think you do have to be opportunistic and understand the importance of a relationship if you want to advance a body of work.
Any last thoughts, ladies?
I think that I would just, first of all, I was delighted to have this opportunity again to look at these organizations, and it always underscored for me just how exciting and innovative they are and the work is that's going on there. But I think I would just underscore the importance of this to the health of the nation as a whole, that it's not, it's not an isolated kind of benefit to look at how to improve research in the safety net, but that it will make increasingly more and more of a difference and be of more significance to any number of health issues and health improvements for the country as a whole. So.
Anna?
And I just want to thank you too. This was wonderful to participate in this conversation. I think that we're at an exciting time. I think we have researchers are going to find data available in ways and in quantities they haven't seen before. And I think it's time for us to reclaim, working on patients' needs and move away from only focusing on sort of funding and those structural policy pieces of healthcare to really talk about health. I mean, I think it's just a really exciting time. I also think that, again, health delivery reform is, I think, really surging across the United States with the Medicaid waivers and a lot of work under those waivers. This is time, I think, for a lot of evaluation. So I just hope that we see partnerships and coupling with the research community and the safety net in ways we haven't seen before, and also strengthening the ways we have seen before. I also want to say that I hope that people, not only if you don't have a safety net organization close to you, you can also think about some of the other safety net organizations like the Essential Hospitals Institute, who really can be the gateway, I think, to a lot of innovative practices that are going on and help make those, I think, connections and build those relationships. So I'm just excited. I hope that this has triggered some thinking and maybe even some energy. And I hope to see in Academy Health more briefs and much more discussion around the safety net in the future. So thanks again for having me today.
Great, thank you. I'd like to thank Anna and Linda both for contributing to today. And I would like to also thank all of you for joining us today and encourage you, in Anna's words, to be bold and be brilliant. So I will also just state that, again, you can go to the showcase feature in the right-hand corner to download Linda's briefs and just read more about the hospitals profiled. But thank you all for joining. Until next time.